I am Professor Dr. Bela Shah. I am working at BJ Medical College and now practicing at Ellisbridge. So today I'll be taking you through the very common cause of facial hypermelanosis, that is melasma, which was also known as chloasma, meaning thereby green colored, but that's a misnomer. It's also known as mask of pregnancy. It is very common disease or disorder which affects females who are in their 30s and 40s. And not only females, but nowadays we see so many males walking in with melasma. So there are so many causes of facial hypermelanosis, and melasma remains the number one cause of facial hypermelanosis. The other common causes what we see in clinical practice are post-inflammatory hyperpigmentation, the rash of acute LE which resolves can give rise to PIH, even dermatomyositis rash, acne, post-acne pigmentation, following any abrasion, any insect bite, macular amyloidosis, pigmented contact dermatitis, LPP. The list is getting bigger by the day as we see increasingly patients with acanthosis nigricans, maturation melanosis with facial hypermelanosis. So, to deal with melasma is becoming challenge, as we know that the recurrences are very common in melasma. So there are so many types of melasma. If you look at the Wood's lamp, we try to localize the pigment in epidermis, whether it is epidermal, whether it is dermal, or it is mixed. But now we know that most of the melasmas are mixed. The most common site wherein you will see the circular patches on the cheeks. Maybe at times the tip of the nose is also involved, and above the eyebrows as well as the philtrum area is also affected. The extrafacial sites wherein the melasma can occur are the neck and the forearms, and this is also not very uncommon. I have seen series of patients wherein we could see the pigment on the forearms as well as on the neck. So it is very important to tell the pathogenesis of melasma. It is not only because of the pregnancy or the OC pills or certain other drugs like phenytoin, but UV light plays a major role in recurrences as well as the persistence of the lesions. So photoprotection is an integral part of any melasma therapy. To highlight the disease and its gravity on the psyche of the patient, because of the chronicity and recurrence of this disease, the quality of life of the patients who suffer from melasma is highly compromised. And at the moment, I do see many patients who relapse very quickly following response to the therapy, but then there are patients who fail to respond to multiple therapies. And with uncontrolled market, the patients do apply many creams which are available over the counter, and they come with complications like exogenous ochronosis or even topical steroid damaged faces on top of melasma. So these patients are very difficult to manage in clinical practice. So we need to understand the pathogenesis of melasma in context of impaired epidermal barrier function as well as role played by vascular endothelial growth factor. So we should focus on the newer aspects of melasma, being apart from the role of UV radiation, oral contraceptive pills or pregnancy. Most of the patients have onset of this disease or the melasma during pregnancy. Few patients can have even postpartum onset of melasma. 20% patients melasma will fade after pregnancy, but most of the time it persists, and then the patients visit us and they seek our advice. There are plethora of creams which are available to address the problem, and the gold standard remains still modified Kligman formula which contains hydroquinone, tretinoic acid as well as steroid. But then nowadays we have seen that the potent steroids are incorporated in many formulations. I think we should do away from those kind of preparations. What are the therapies which are better than hydroquinone? And now we have so many other products like kojic acid, arbutin, and glycolic acid containing creams. We can also club our therapy by adding chemical pills when the patients fail to respond adequately, say after 12 to 16 weeks of topical therapy. So it is very, very important to club and add glycolic acid pill 30% to begin with, and gradually we can increase the percentage as per the clinical response. For refractory melasma, we have many other options like adding tranexamic acid orally, 250 milligram twice in a day. We can also give intralesional tranexamic acid, and that also works out to be a better option in cases who are refractory to the medical treatment as well as chemical pill therapy. So what about role of lasers? Is it a magic wand? Probably for our type of skin, laser is not a really good option because our type of skin tends to pigment very easily. So if you do not choose the adequate fluence, if you choose higher fluence, the patients might land up with complications like post-inflammatory hyperpigmentation, and the pigmentation for which the patient has come to us can get worse. So to use laser, we should be quite cautious, and our parameters should be, the fluence should be quite low to begin with. And number of lasers which can be utilized for melasma are IPL and Q-switch NDN laser, like that. But then my experience of lasers is not very good, but we can always use medical management along with the newer topical therapies which are easily available to us, including various flavonoids containing creams. But we need to remember that apart from our medical therapy, role of protection from the sun should be overemphasized in every case, and we should always prescribe a sunblock cream which the patient has to use even if she or he remains in the house, because there are so many other sources of light coming in the house itself, like radiation from the devices. Everybody is using mobile, laptops. So ideally the sunscreen for melasma should contain iron oxide, and iron oxide containing sunscreen will be ideal, and it has to be applied at least half an hour before going into sunlight. So protection against UVA and UVB is mandatory, and patient has to follow the sun protection measures by wearing appropriate clothing as well as putting on large goggles which can cover part of the face, and that might be one of the beneficial add-on therapy for addressing the patients who have got melasma.
For more such videos, visit or log into dermavidya.com.